All right, welcome to another six pattern video. My name is Max.
My name is Kevin.
And today we're looking at a case from Atlanta, Georgia.
Great.
The Southeast.
That's important to reflect a little bit on where you live to figure out what diseases, if any, you're at risk for.
It's humid down there.
It's humid.
Very humid. So this is from Atlanta, and this comes from a 44-year-old female. And she has a long history of rheumatoid arthritis. In fact, she's being treated with methotrexate. She has been being treated with methotrexate for years now. And it actually has been fairly well controlled, her rheumatoid arthritis. But lately, she's been having some increasing shortness of breath and cough. And she had some imaging studies. And the imaging studies showed some bilateral, vague, fuzzy ground glass with maybe a little bit of nodularity.
Wow. So she has rheumatoid arthritis. She's being treated for her peripheral disease, right? Because we don't think of rheumatoid arthritis as a lung isolated disease. Although it can happen.
Yep.
We generally think about joints, right? So her joint disease might be under control with methotrexate and low-dose corticosteroid, which is more typical than other therapies because it's very inexpensive. So here we have a patient who has a lung biopsy in the setting of known connective tissue disease.
And known immunosuppression. So for the rheumatologist or the pulmonologist, what are the main things they're thinking about for new infiltrates in the lung? Could this be a manifestation of the underlying connective tissue disease?
Right, like nodules of RA, right?
Could this be an infectious process?
A patient's immunocompromised, it is a risk.
Right. Could this be a drug reaction?
A drug reaction.
Because we know methotrexate can cause interstitial drug reaction and interstitial lung disease.
So those are the three questions that always come up in your rheumatic disease patient who has new infiltrates in the lung. So the clinicians tend to look at that differential diagnosis and say, well, can we resolve this just by saying we think it's methotrexate and stop the methotrexate? Can we just say it's infection and just treat with broad spectrum antibiotics? Or do we think this is actually a new manifestation of the patient's rheumatic disease? So in this case, they've done a biopsy, which means they were not able to answer that question. There must have been something about the presentation that was a little odd, meaning the patient...
Clinically, they're unsure.
Right. And the patient probably got fever.
Right.
The patient's probably actually pretty sick.
Which fever can be seen in any of those three differential diagnoses.
But the degree of acuity might be scaring them into getting a biopsy. Maybe they tried to get a transbronch biopsy. Maybe they tried a lavage to no avail. So here we are with a piece of lung tissue. What do you think?
Now, even before we look at this, just from a clinical perspective, if you're having a conversation with your pulmonologist, what things might help you in that differential diagnosis when you're having that conversation? I always like to think, I like to ask them, well, how's the joint symptoms doing? Right. Because if the patient's having a terrible flare of joint symptoms, right, then that would be more concerning to me that this might be a pulmonary manifestation of connective tissue disease, because the connective tissue disease we know is flaring elsewhere in the body.
Right.
The other question that I always ask is the timing of the medications. Right. Did we recently switch to a new medication?
Right.
In this particular case, methotrexate has been on board for years, and she's been doing fairly well, and she's not having a flare.
And it's interesting to note that the majority of patients who develop methotrexate pulmonary drug toxicity do so in the first month of therapy.
Fairly early. So I think just with that extra bit of clinical detail, I think we go into this biopsy saying, well, maybe ILD flare is less likely, maybe drug reaction is less likely, but certainly they still are possibilities, and that's why we're looking at the biopsy to see.
Yeah.
So low power, what did we see, Kevin, on the biopsy?
Well, there's a lot of blood, and don't be confused by blood. Some surgical biopsies will have more blood than others. So I kind of subtract the blood. I don't immediately think about alveolar hemorrhage syndromes or vasculitis. I subtract the blood, and I look at something that is sort of doesn't belong here other than blood. And to me, we've got these bluish nodules with lighter pink or gray centers.
Exactly.
So this is nodular disease.
So just to confirm, right, this blood that we see at high power, These are normal, thin, delicate alveolar walls in the background. This isn't consolidation or anything. This is just fresh red blood cells, which is probably an artifact.
And some atelectasis here in the biopsy.
Right.
It's probably left without being shaken.
Right. Artifact of the procedure itself.
Right.
Okay, but what we're really interested in are these large nodules.
Right. And within the large nodule, there are multiple smaller nodules.
Exactly, like this, and this, and this.
And a lot of lymphoid.
And a lot of lymphoid infiltrate.
Right.
So what's going on with these smaller nodules?
Well, to me, that's a classic granuloma. So we've got a non-necrotizing granuloma at the right side of that field, surrounded by a cuff of lymphoid cells, a giant cell here within, or a couple of giant cells, making a small granuloma, sort of a classic pulmonary granuloma. The granulomas are pretty loose, even though they're distinct by the cuffing of lymphocytes.
They are loose. Now, as far as distribution of these, right, this is a very nodular process. And someone once told me that any nodular process in the lung is probably airway centered.
Yeah, most of the time it will be.
And in fact, here is the proof in the pudding. Here's an airway. There's your respiratory epithelium. And the other half of this airway is completely destroyed by
necrosis.
Necrotizing granulomatous inflammation.
So, granulomas with necrosis. Let's look at the poster.
Great idea. Let's look at the poster. So we've got nodules, right? And so we're going to look a little bit more closely at the nodules pattern here. And in that nodules pattern, what are we supposed to look for underneath? Let's see here.
Well, the first one is, are there granulomas with necrosis?
So yes, we have granulomas with necrosis. So infection, aspiration, Wegener, and necrotizing sarcoid. So is it Wegener? There's blood in the background.
Yeah, I mean, you'd think with all that hemorrhage, and now we've got necrosis and granulomatosis, why isn't it? Well, I'll tell you a little secret. This is a pearl. If you find well-formed granulomas without necrosis in a case that you're considering GPA, it's off the table. So patients with GPA don't make granulomas without necrosis at the center.
Right. In this case, we saw a bunch of those. That first nodule, a bunch of loose granulomas.
Without necrosis.
But definitely clear granulomas.
Yeah.
So it's not Wegener's. We can eliminate that. Necrotizing sarcoid.
Well,
rare.
Form of vasculitis, kind of looking a little like GPA in some ways. So I think we can take that off the table.
I think so too. So we're left with infection and aspiration.
Right.
Now, remember our clinical scenario. We went into this with infection kind of at the top of our differential diagnosis.
Right.
And we've seen nothing so far to argue against that. In fact, everything we've seen so far supports infection as the etiology for this nodular disease in a patient with rheumatoid arthritis.
So I wouldn't do any more in this case until I had special stains.
Yeah, and of course that's what you would do. Now, what would you get?
I'd get an acid-fast stain of choice, whatever you like. Maybe even auramine rhodamine if you can do it in your lab, if you have a fluorescent scope. A GMS for sure, Grocott.
I think that's about it.
That's about it.
That's all I would do on this case.
Yeah.
So in this particular case, remember she's from Atlanta, so this case was positive for multiple fungal organisms, particularly within these areas of necrosis. And the fungal organisms looked a lot like Blastomycoses.
Which is endemic in the southeastern United States.
And sure enough, the culture studies were positive for blasto. So 44-year-old patient with rheumatoid arthritis, immunosuppressed on methotrexate with an blastomycosis pneumonia secondary to the immunosuppression.
Solved.
Case solved, and very clear direction for the clinicians on what to do next, and that's the antifungals.
Great.
All right. Hope you enjoyed the case. Don't forget to like and comment below and let us know your thoughts. Thank you.